September has been dedicated for prostate cancer awareness campaign that we should spread the gospel, even though we all know about prostate cancer. But it is good that we remind ourselves how the disease is and all the nitty-gritties about it, so that we can help us to prolong our lives as individuals. So this morning we are just going to go through a few things that I believe that we know already, but we will remind ourselves and also add on to our knowledge what we already know. So someone asked, what is prostate at all? So the prostate that we all have, that some of us have not even seen before, it is a small gland. Usually we describe it as a walnut shape. It is located at the base of the bladder, and it surrounds what we call the urethra. The urethra is the tube that your urine passes through. So this is your bladder, where the urine stores from your kidney. So when you want to void or urinate, it passes through this space or this channel and comes out to your penis or to your urethra. So the prostate surrounds the upper part of the urethra. So the prostate also has its functions. It's not just at the upper part of the urethra. It also helps with the closure of the bladder neck, so that you can control when you are storing your urine. You see, this is the bladder, this is the gate of the bladder. So the prostate reinforces the gate, more or less like the security man at the gate, like a gatekeeper. In fact, the term prostate is prostato from a Latin word. That means it's a gatekeeper. So it reinforces that gate. That is why when you want to void, you really feel like you want to void, you are in church or you are doing something, you can hold, you are in a car, you can hold for some time before you go and void. The prostate also contributes to that. But its main function is it produces some fluid that we call prostatic fluids. The fluid that we see in our semen when we ejaculate, when we are having our fun, most of that fluid that we see is not a sperm. Most of that fluid is semen. In the semen, most of it, over 30%, is produced by the prostate. So that is a key function, and that fluid, the prostatic fluid, is what nourishes the sperm, for the sperm to gain its strength and energy to survive. And then when it gets to the woman, it can swim, and then dive and go to the fallopian tubes and go and look for the egg to fertilize. So that is the main function of the prostate. And like I said, because it is located at the upper part of the urethra, when it gets big, so this is a normal one. So this picture, first picture, is like the individual has been cut, like divided like this. So the penis is divided, so it has been cut. We call it a sagittal view. So you see half of it and then part of the penis. If you look at this image, so this is the prostate. So clearly, you see the channel is clearly patent or open. If you look at the second image, let's go to the third image. You see that it has the channel has been encroached. So this person can void, but when he is voiding, he will have some feeling of some difficulty. Sometimes there's something we say straining. He will strain, he will push before the urine comes. There's something called strangling, there's something called hesitancy before the urine comes. But some will come, but to come small, and sometimes even after urinating, you feel like there's some left. And then at this stage, in fact, you see that it is completely closed for your face. So at this stage, urine cannot pass through at all. But this enlargement is not necessarily cancer. This enlargement and the issues that the problems that I just mentioned are not specific for cancer, because usually there are zones of the prostate, and we say that the cancer, about 70% of the cancer comes from the peripheral zones, that is the outer part of the prostate. But the innermost prostate gland that surrounds the urethra, just a small percentage of cancer usually arises from there. So if somebody develops those symptoms, it is not necessarily prostate cancer, even though it can be prostate cancer. So let's look at some statistics. In fact, you know, this country, research is quite low. So we don't have a lot of data, but we'll try our best possible. So Prostate cancer is the commonest, in fact, in some parts of the world is the commonest. But if you are looking at the worldwide picture, it is the second commonest, second to lung cancer. Because you know elsewhere, smoking is key. If you don't smoke, you are not a human being, kind of. So it is the second commonest cancer worldwide. But if I try to look at some of the statistics, so I just chose UK statistics. In the United Kingdom, more than 52,000 men are diagnosed of prostate cancer every year. More than 52,000 men every year. And that means that about 144 men are diagnosed every day of prostate cancer. That means, and then they also look at the rate of death. And every 45 minutes, one man dies from prostate cancer. That sums up to more than 12,000 men every year from prostate cancer. And when you say death from prostate cancer, it means death that is directly as a result of the prostate cancer. The prostate cancer can lead to other complications. The prostate cancer can even lead to kidney failure. But if you die from kidney failure, usually we don't attribute it to prostate cancer. You understand? But death that is directly related. Sometimes there's a secondary cause. For somebody may have other diseases that is probably causing the death. But these deaths are actually directly related to the cancer itself. So if you see lower values, don't be so excited that oh, cancer no crying. It can really, just like somebody mentioned earlier, it really kills. So general statistics, if you take 8 men, but one of them will have prostate cancer in his lifetime. If you take 8 men, like how many of us are here? 1, 2, 3, 4, 5, 6, 7, 8, 9 men. That means those of us just here, one person will get prostate cancer. That is how it is. 1 out of 8 men will develop prostate cancer in their lifetime. And then out of the number of people who develop prostate cancer, if you take 40, 1 will die directly from the prostate cancer. But the morbidity, when I say the morbidity, the other sicknesses and what bothersome conditions related to prostate cancer, even if it doesn't kill you directly, your life will not be the same. Your quality of life will not be the same. You will not enjoy your sexual life. You will not. It can paralyze you completely. Your urine will become some way. You waste. I mean, your weight will reduce. You shrink. It does all sorts of horrible things, even if it does not kill you. So sometimes it's even better if you are dead. So it's a very devastating disease. And men, it's a disease that we say that is very common in the aged as you are growing. So we say that 80% of men at 80 years will have prostate cancer. So men who are 80 years, sometimes you wonder if it's good to live longer or not. Men who are 80 years, when we sample men who are 80 years, about 80% of them will have prostate cancer disease in their prostate. And the last one is something that in Kolibu generally and in the country at large, because we are not very keen about taking care of our prostates, and we really resort to a lot of herbal and other forms of treatment, we present very late. So about 80% of men who go to the hospital with prostate-related conditions present very late. At that stage, it is late. So it means whatever we can do, we are just managing. But we are not aiming to achieve anything that is very substantial. But we are just trying to manage it condition so that the disease takes its course. So let's look at some risk factors. I already earlier on mentioned about age. So like I said, it is a disease that is commoner. In fact, it's a disease of the aged. As you are aging, somebody will say that you have worked your whole life and now you are going to retirement on 60. So you think you are finished, you are going to enjoy your little money you saved and enjoy your life. But commonly after 65 is where it starts hitting you hard. 65 to 70, 75, it is a peak age that the cancer really manifests itself. And it's a very slow growing cancer. So sometimes it can start earlier, but at that time, then it really manifests itself, and then you start having the signs and symptoms associated with it. Personally, I have seen 38, 39 years with prostate cancer. Clinically significant prostate cancer, 38, 39 years, that we had to do surgery to see the person quickly. As early as 38, 39. The literature says it's less common 40 years. But I have seen 38 years myself, 39 years myself. So it means that the age is reducing. We are in the modern age, modern era, so everything is cutting down. So it means that it is very important that we take very good care of ourselves. We don't have to even wait till we get to 50. Sister, your mother, father, second degree, your uncles, aunties, nieces, and nephews all come into the picture. So if it's a first degree, that is the level. If it's a second degree, your risk is still increased, but not as high as a first degree relative. And then aside the prostate and the breast cancer itself, there are other cancers like colon cancer, stomach or gastric cancer, small intestine cancers, they are all ovarian cancer. They are all related because of genetic predisposition. There are some gene mutations that are common. They run through those cancers. So if somebody in the family has that cancer, you stand at a higher chance of developing some of these cancers as well. So we should be interested if our relative is sick in the hospital and then God forbid the person passes on. We should be interested what the person is suffering for. And then many a times somebody passes on, doctors want to request postmortem. Then relatives will come, oh doctor, what else? Let's just go and bury the person. Sometimes it's because of some of these things. Because if you know your family member died of prostate cancer and it's a first degree, let's say your father died of prostate cancer, you stand at a very high risk. You can develop prostate cancer even before 40 years. But if you don't know that your father died of prostate cancer, what will stimulate you? Family history is key, so that it can inform us on the decisions to take in spite of or in respect of prostate cancer. Like American, blacks in general. But when you go to the Western, the whites, it is less common. So even the UK statistics are presented, that was, we are all marvel. That is UK within in the whites. So you can imagine if you have data, proper statistics in the country. So in the Asians and all those people, it is believed that it is less. Sometimes they say because of the environment, because of the food they eat, and then all that. But it is commoner in blacks. And it is, aside the prevalence in black, it is more aggressive in blacks. So you and I are black.
It's a racist cancer.
You and I are black. So we have to be very cautious of it. And HPV virus, which is also associated with cervical cancer, has also been directly linked to prostate cancer. There are some promoters that all this I'm saying, we don't actually know the exact cause. All these things are associations which certain people have done that we can associate it with. So there are some promoters, but the key promoter is testosterone. If you give birth or if you're a teenager and you remove your two testes, you can be sure almost 100% that you will never get prostate cancer. If you are a child and you take both two testes out, or your puberty, you take both, because testosterone is the key stimulator. Aside it being a stimulator, it also promotes its growth. In fact, we say that the testosterone feeds the cancer. And we know the World Bank of testosterone, that's our testes. So sometimes as part of the treatment, we have to remove your testes as part of the treatment. So testosterone, remove both. It is one of the commonest things. In fact, at a certain stage, when you come and it is advanced, we either remove physically as in surgery or give you medications that will block the testosterone. So even though the testes will be there, but it will not be working. So it's part of the treatment. I will talk about how we did it, but that is the World Bank of the testosterone. So testosterone is key. And then we have some other arachidonic acid, omega-6. They say that high fat. Yeah, red meat. And I hear there's a pork party going on somewhere. And all that. So, fatty meat, red meat has been associated strongly with it. Dairy foods, milk, cheese, what are some of the dairy foods, right? Cheese, yogurt, ice cream, they are all associated. Obesity is part, but usually obesity does not stimulate its cause, but it's really associated with the aggressiveness of the disease. Same with smoking because of cadmium exposure. Alcohol has also been associated with aggressiveness of the disease. And also, and also the progression of the disease. Alcohol. That one I can't say that. Look for us and tell the world.
Anyway, the alcohol is qualified. High alcohol.
High alcohol.
How high is the high?
Okay. But there's also a good news. There are some inhibitors. There are some things that have been associated that if those things are also in your blood or in your system, they try to inhibit it a little. So, estrogen, I mentioned testosterone as key, and estrogen, and that is why men and women are opposite. You understand? So, what testosterone is doing, estrogen will do the other one. Puberty, what estrogen is, testosterone is producing, estrogen will be doing the other way around. So, estrogen is associated to be an inhibitor. It reduces or it decreases the pace of progression and the aggressiveness of it. So some of the Asians, they have some foods that have phyto, like some food that has some estrogens. And even there's a drug called dihydrotestosterone. At a stage where the prostate cancer, we think that, Charlie, right now, we don't know what to do again. We can put you on that drug, and that drug is estrogen based. Even though it has its own side effects, but that drug is estrogen based. So estrogen is one of the things that is said to inhibit the progression or the severity of the disease. Vitamin D.
Estrogen, maybe we find it local.
We need research, and our pharmacy manager is here. We need research.
You refer to the nutrition.
We need research. We need research. So vitamin D, in fact, has been associated that men who have low vitamin D are likely to develop prostate cancer. And then people with prostate cancer who have low vitamin D are linked to having more aggressive diseases. But people with already prostate cancer who have a normal vitamin D have a less aggressive disease. So sometimes in our treatment, we add vitamin D as a supplement to our patients. So vitamin D is key. And vitamin D, we all know the source of vitamin D.
No, I don't know.
So vitamin D, early morning sun. So early morning sun, abundant of vitamin D. So other countries where sunlight is less or is not common, in fact, prostate cancer risk is higher. But we have it in abundance. We have all these things, but still the disease is very aggressive and very common in blacks. So the more we do that is we exercise early morning. We do our early morning exercises in the sun, helps. Antioxidants, which are very common in red fruits and vegetables. Anything red, fruit and vegetable. I'm sure. As a fruit and vegetable. So, like tomatoes, guava, the pink one, watermelon, pink grapefruits, and all that. They say it contains some antioxidants called lycopene. It's very important. There's something we call insulin-like growth factor, and all that. It helps to reduce the amount in our circulation, and that thing promotes growth and then cancer progression. So once you have all these things and then it tries to reduce the level, it helps. Then broccoli, I'm sure you all know broccoli. That fruit, very, very red. Ghana, I've not really seen one.
It's here. It's here that
but we don't know how to eat it. actually, but it also has been associated to be a good inhibitor of it. Omega-3 unsaturated fatty acids, which is common in fish oils, salmons, herrings, and all those things. Mackerel, they are also good. And like I mentioned, dairy diet. So if your diet does not contain dairy products or dairy food, it helps to reduce the circulating IGF. That's what I mentioned as insulin-like growth factor, which is a promoter, a growth regulator. So if the levels in your blood is good, it helps put you at a better chance of. So there was a study that was done with about 142,000 men, and these people were followed up for about 8 years, and then it was reviewed that these men were taking dairy foods. It was reviewed that their risk increased because of the dairy foods that they were exposed compared to the control that they had. Exercise is also good. It also tends to reduce the IGF, probably because people exercise outside. I know people, like somebody here I know does a lot of exercises indoor, but I know most exercises are outside. Because studies have also proven that there were men, about 47,000 men who were more than 65 years, who have 3 hours a week of vigorous exercise. The study also brought out that even those who had cancer, they had a very low-grade cancer. And I'll tell you the benefit of having a low-grade cancer. In fact, prostate cancer is a very wonderful cancer. It's a cancer that sometimes at a certain age, you'll be happy you want to have it. At a certain stage, you'll be happy you want to have it. And then other tests also reviewed about 190 subjects who had prostate biopsies. Out of these people, those who had 1 hour per week of vigorous exercise, they were less likely diagnosed of prostate cancer. And then people who had mild to moderate exercise, 1 hour per week, also had low grade. So the more vigorous the exercise and the more prolonged the exercise is, it reduces your risk significantly. Clinical presentation, what can tell or what will you feel for you to say or for someone to say, hey, it looks like I have prostate cancer? Generally, it is asymptomatic. You may not feel anything. I have seen one patient, 60 years. The patient just urinated once and felt some small pain, and then decided to go to the hospital. He did his test, PSA was like 2 point something. He did ultrasound, prostate was small. He was urinating, everything was fine. And when he came, assessed him, he realized that he has a disease. So it can be asymptomatic. That is why it is important that you know, as we captioned it earlier, you know your PSA numbers. It is not very specific, but I will tell you how PSA helps with monitoring of your prostate cancer. And then even if you have symptoms, like I said, you can have symptoms, but these symptoms are largely non-specific to cancer. Like I mentioned earlier on, because of the way the prostate grows, it can block that channel. And when it blocks that channel, you can have difficulty urinating. It can be that it's cancer. It can be that it's not cancer. It can be that you even have tuberculosis of the prostate. It can be you have just bacterial prostatitis. It can be anything. It can be that you're taking a lot of alcohol, and then there's inflammatory process in the prostate. It can even be viral prostatitis. But it can, so long as it has gotten bigger, it will narrow that space. Okay, I have this picture here. It will narrow this space, and while this space is narrowed, all these things are possible to happen. So it can be symptomatic, but these symptoms may not be necessary. But something like a bone pain or waist, lower back pain is one of the commonest presentation. But if you have lower back pain that is associated with prostate cancer, then it means it is advanced. Because look at where your prostate is, and you are having the lower back pain. It means it has spread to your bones or to your back. So these signs and symptoms can guide you, but like I said, largely it is asymptomatic, and some of these signs and symptoms are not specific. But again, I will re-emphasize, even though they are not specific, when you have them, I will encourage you to go to the hospital. In fact, see a urologist so that they can evaluate you adequately and be sure that there's nothing hidden somewhere. So diagnosis, now you've come to the hospital. So what do we do to tell? So clinical assessment is key. And this clinical assessment involves history. Like I mentioned earlier, history taking. Just the mere fact that you have a family history of prostate cancer is key. And once again, I will emphasize, let's be interested in the conditions that our family members go to the hospital, in conditions our family members were suffering from before their demise. It is very important. These things will help us a lot so that to keep the rest of us alive. And then, as part of the clinical assessment, we also have examination, and digital rectal examination is key. Let me give you this story. I think 2 weeks ago, I was in the clinic, and a man came. My boss sent a man to me to evaluate him and then get back to him. But the man came, he's an accountant somewhere. Oh, he's fine, his PSA is fine. It's just that he has some pain. The scan, and then the scan said the prostate size is 23. In fact, I forgot to mention earlier, the normal size of the prostate is about 25 grams. To about 15 to about 25 grams is a normal size. So when you do ultrasound and it's bigger than that range, you will say that it's getting bigger. But the more, usually it becomes clinically significant from 30 going. But sometimes it can be small. But it depends on how it goes. Let me just go back a little and show you this. So if you look at this picture, it has grown outward and then it has narrowed this passageway. But you see there's something here. That's what we call the medial lobe. Sometimes the prostate itself may not be too big, but the medial lobe has grown into the bladder and it is obstructing the bladder outlet. So sometimes the size alone cannot give you the clue that it is enlarged, because ultrasound does not measure that middle part of the lobe. So laboratory-wise, PSA is the commonest thing that we use now. The PSA is also not very specific because even if you have sexual intercourse, it can raise your PSA. If you have any vigorous activity, like even exercises, riding bicycle, exercise, athletics, it can raise your PSA. But usually it is mild and it subsides after a certain number of hours or days, it comes down. But if it is as a result of a disease, it will persist. So a high PSA one day does not mean you have prostate cancer. Aside that, you can have benign, as in there's no cancer, there's no tumor inside, but the mere fact that it has become big can also increase your PSA. That doesn't mean that I've seen people over 200 nanogram per mil. PSA, the usual range is, they say 0 to 4, but there's age-adjusted PSAs. So let's say if you are 40 to 49, you say that, oh, your upper border is about 2.5. When you say you are 50 to 59, you say about 3.5. 60 to 69, you say about 4.5. But if you are about 70 to 79, you say about 6.5 as your upper border. So it is not everyone who has more than 0 to 4, because the laboratory lab will write 0 to 4. But there's age specifics and low prostate. So like the story I was trying to give. This man came, he was fine, the prostate was 23 grams. And I gave you the normal to be about 15 to 25, so it means it's within the normal range. It doesn't have any symptoms. His PSA is 0.666. When I saw it, I even thought it was 666 that he has. It's an antichrist that is 0.666. But when I did my clinical examination and I put my finger in the anus, sorry for my words, but that's a digital rectal examination. We put our fingers in your anus to examine the prostate. I think I had a picture like this. So you put the prostate is very close to the rectum. So if you want to evaluate it, you put our finger through your anus, and this is what a lot of people don't like. People don't even want to go to hospital because of this. But we always lubricate our hands as best as possible. It's a little uncomfortable, but this examination.
But why do you call it digital? When you are using
Digital, because you are using digits.
okay.
So it's not digital as in IT digital. Your fingers are digits. So in digital rectal examination. So you put your finger there, then you can feel the prostate. If there's a cancer, you can feel. And then the consistency of the prostate can tell whether there's suspicious nodules or not. So clinical examination. So this man with 0.66 and all that, I put my finger there, and lo and behold, the things I felt. I went to give my boss the feedback. He said, "Oh, what? I should have called him to come and feel." I saw even on one side. I called him there, positioning the patient. Then he also called and said, "Yes, you are right." He even felt more because his fingers are longer than mine.
So you push further.
He pushed further and even found more. This is somebody whose PSA was fine. Has virtually no symptoms. But that pain that he was describing can just be a arthritis or a cystitis or can be anything. And his PSA was very low, 0.66, but we found something there. So,
Please, can I ask a question? If your PSA value is okay, you come to the lab and you do it's okay. From what you just told, it means you need to go further and do the pathological assessment as well.
No, not necessarily. So you let me that. So the laboratory, the PSA will be good. Like I said, it's not very specific, but it will be good for us because if you do a PSA one time, let's say PSA is 10, this PSA is high. Then at that time, probably the doctor has done his clinical examination, didn't find anything suspicious. So he will tell you to go and come back probably in a period, maybe 3 months time, and then repeat the PSA. If it was because of some of the things I've mentioned, it will can come down. Sometimes you can have prostatitis and your symptoms will present, the doctor may think, oh, this is an infection. Let me put this person on an antibiotic course and re-evaluate him after this period. And if it is an infection, it will come down from the 10 to any other value that it can drop to. But significantly, if you do a PSA, just like my senior brother is saying, and it is normal, let's say it is 3, and then after 6 months you do it again, it's 3.5. 1 year is now 4. In 2 years' time, it is now probably 6. So we use something we call PSA dynamics. There's something we call PSA velocity. There's something we call PSA density. There's something we call PSA doubling time. So the rate at which the PSA is progressing gives us a clue that no, this is not a normal progression of the PSA. That is why we should know our numbers. If you know that you are number 2, after 6 months, 1 year, you do a PSA, now you are 2.5. 0.5 is very significant. You understand? So it depends on the rate at which your PSA is going. But if you don't know your baseline PSA at all, and then because there are people with PSAs, like I said, over 200, but it is still benign. There is no cancer. But if you don't know your baseline, and I've also mentioned that there's somebody with PSA of 2.something, 2.4, but the person had cancer. Somebody of 0.66, and the person had something in there. So it is always good to know your PSA baseline. And this can only be best evaluated by somebody who has been trained in that area. That is why I advise that you see a urologist. Understand? Then if after all these things we now see something suspicious, your PSA picture tells us and gives us a clue that no, this one is a pathological PSA rise. Then we now subject you to the pathological assessment, which is a biopsy. We now take portions of your prostate and now send to the pathologist to also analyze under microscope and tell us if he's able to find any prostate cancer cells. then we can now diagnose you as having prostate cancer. Aside that, based on the stage, we can also do other imaging like MRI. And MRI, let me put it this way, elsewhere, because the DRE is quite uncomfortable, somewhere in Europe, there are some countries they have banned DRE, digital rectal examination. So we shouldn't stick our fingers in there. So what they do is, you come, you do your PSA. Your PSA is suspicious or suspiciously high. Then you go to the radiological MRI. Not just any MRI. There's one we call multi-parametric MRI. That can help us to diagnose if there's a prostate there or not. Because if you do an MRI, it says there's no prostate. There can be prostate cancer. But if a prostate cancer that multi-parametric MRI does not pick, is a clinically insignificant prostate cancer. And that is the prostate cancer you want to have. That kind of prostate cancer, there's something we call active surveillance. We just watch, oh, you have prostate cancer, but you go. Every 6 months, you come and show yourself to us, do a PSA. Once a while, maybe once every year or once every 2 years, we do the MRI to see. We just live your life. Meanwhile, you have the cancer sitting in there. So that is one of the things that can be done with radiological. Sometimes when you can't feel that it is advanced, you want to find out whether it has actually spread and where it has spread to. So we also do other images, like you can do MRI. That's in that case, you do a full body diffusion weighted MRI. You can do a bone scan. You can do PSMA test scans and other radiological investigations. That will help us to make our diagnosis. So treatment options, it will be based on the stage. Prostate cancer treatment is very, very difficult and challenging. But the early stage is where we all want to get to the disease. That's what I'm saying. At that stage, we can be asked to go home and drink your malt and your Fanta and eat your food. There will not be any treatment for you. The early stage. Because the danger is that when you miss the early stage, it becomes very difficult when it's advanced. Because at the advanced stage, like I said, and then the early stage, before I go to the advanced, there are other treatment options. Aside me saying go home, just let us watch. There are some people, they will say, Doctor, because I know there's cancer there, when I sleep, I can't sleep, I want you to take it out. Good. So there's something we call radical prostatectomy. We take the whole of the prostate and the S capsule out. There's no prostate cancer has been taken out. So in quote, we say you are cured. In quote, you are cured. Because the cancer is very small. I will show you other pictures of how small it can be. And then the whole gland has been taken out and blocked. So you are cured. You can also have something we call brachytherapy. It is also a form of radiotherapy that we can inject to that point where the cancer cells are to kill the cancer cells, and then we'll monitor you for some time. But when it is advanced, we can still do, it depends on the stages. There are different stages. There's a low risk, there's even a very low risk, a low risk, intermediate risk, a high risk, a very high risk. Every stage has its treatment options. There are some stages you can still do the surgery. But after the surgery, you still have to do radiotherapy in addition, or sometimes even chemotherapy. I mentioned that the testosterone, we can sometimes remove the testes. That's the hormonal treatment. When it's advanced, you have to add the hormonal treatment. And then the hormonal treatment, aside the removal of the testes, that's the bilateral orchidectomy, you can also do medications, that's the chemical castration. So there's a surgical castration, there's a chemical castration. But what is worrisome is that you can still do this castration and it will go on after some time. Then there's something we call hormone refractory prostate cancer. Now the prostate will give up. 10% of the testosterone is from the testes. But we have a gland called adrenal glands. It is some small fatty tissues on top of our kidneys. It also produces some of this testosterone. Sometimes it also starts producing more so that it can nourish and feed the cancer cells, and the cancer starts growing. Sometimes you can even do the full radical prostatectomy. I'm saying you remove the whole prostate, but because it was advanced, There are some small seedlings that may be left. Then it will also start growing. It is very difficult. And at that stage, life is, I know one man, I don't want to describe him, but it is a sad situation. The man has put in his effort, but he erred at a point. He had every advantage of getting rid of the disease. But at the point he thought, oh, at this time, at this stage, everything is fine. He started defaulting treatment a little. He took his treatment into his own hands. And now everything has gotten out of hand. The man has been having all the treatment. The man has had radiotherapy before. The man has done everything. Still, his prostate is rising. Now he's almost paralyzed. And this is an educated person. He's an auditor somewhere. A retired auditor somewhere. He has put in all. And in fact, prostate cancer treatment is expensive. It is not a disease for the poor. But unfortunately, the prostate is with the poor and then the rich. It is very expensive. These things are mentioned like that. They are very expensive. This hormonal treatment, if you don't want your testing to be removed, you have to put you on some medications. The medications, cumulative amount, you spend about 4,000. There are some drugs you have to put you on that you take daily. Averagely about 2,000 to 3,000 a month. Then you have to give you some injection. The injection alone is about 4,000, and you have to take it every 3 months. That is just one side of the treatment. There are other things that we add. It is very expensive, so you don't want to go there. That is why we are making all this noise. We are going through all this stress. We have trouble, Dr. Kingsley. What we have gone through before today, we can even meet here today. Only God knows. But we encourage each other, we move on. But so that we can carry this message across, that we want to see, we cannot prevent it. We cannot tell. All these inhibitors I'm saying, like I said, are associations. We cannot entirely prevent it. But even if it is there or it will come, we want to see everybody at this early stage. We want to see everybody at the early stage so that something can be done. So like I was describing, at this stage, this is a small cancer here. So if you move the whole of this gland, there's no cancer left behind. At this stage too, the cancer is confined to the prostate. It is not anywhere close to the border. We can remove all this gland and then we'll follow the patient up. This is the stage that I said we can decide to watch the patient. If you watch it is progressing, it gets to this stage, then quickly we intervene. But there are people who can be here and can be here for life. They won't progress. So there's no point treating them. Okay. And then but when you get here, already it is here. So it is very clear that it's possible that it has moved. At this stage, even if you remove this gland, it's possible you have still left something behind. And then at this stage, it has even moved to the lymph nodes. So we want to catch the people early. These are other treatment modalities like I mentioned. They are all there. There's even, they say a vaccine, but that vaccine too is something else. There's not a vaccine to prevent prostate cancer. That one, if you have prostate cancer, nothing can be done. Then they do something so that to slow the pace at which it is killing you. So there's no remedy actually when it gets to advance. Can go to your lungs. Look at this person, it is in the bones. It has spread almost everywhere. At this stage, there's very little that can be done. We can only manage you. So the radical prostatectomy that I was trying to describe, there's a bladder, there's a urethra, that's the tube I described, there's a prostate. So you take the whole prostate out, then you join the urethra to the bladder. Finito, there's no prostate. And then you have your in-code kill. Then you move on. Your nerves, these are the nerves that helps you with your erections. All these ones in very good hands, they can be preserved. And you still have your erections and continue with your life.
If they are removing and they are not careful, they can cut the
Of course.
The erection circuit.
Of course. Or sometimes when you are removing them, everything, some of the tumor, if it's advanced, has infiltrated and then we will sacrifice it. Because your life is before your sex life. If you don't have a life, how can you have sex?
It's a matter of choice.
So like this is a live picture that has been taken out en bloc together with the seminal vesicles nicely. So this is the prostate has been taken out, has been joined. So with this kind of surgeries, you can have complete cure. There are other modalities. This is the laparoscopic, they are robotic. We pray that with time, Gapuha equips us more so that we can do some of these beautiful surgeries. Yeah, these surgeries will do blood loss is about 5 mils. I'm sure my laboratory specialist here will tell us 5 mils, small blood mils, kitty be 5 mils. How can I estimate 5 mils? What can I use to estimate 5 mils? Something small. Teaspoon.
No. Teaspoon is 5.
Teaspoon is 5 mils. This is the open one. So we cut here, too, and then we open you up like this. And then go and accept. This one you can lose. I've seen people who have lost 2.5 liters of blood on table. Just on the table. You finish, we give you like 4 minutes, it's still not enough. It's open. So I intentionally brought this picture. Gapoha should equip us more so that we can do some of these beautiful ones, and probably to be the first in the country. This machine is not in the country at all. Robotic surgeries, they are nowhere in the country, but very beautiful. You do your surgery, blood loss later. You don't need to donate blood for transfusion, and within the following day, sometimes on the same day, you can go home. Very beautiful. But these are the open procedures too that can be done. Then radiotherapy, these are also, they put you in this machine, directs the images to the prostate, and then radiate your prostate with the cancer. These are all forms of radiotherapy that is available. So this is what we have available. So mortality and survival. Prostate cancer is very slow growing. So we say that 5 years survival is about 100%, and then about 10 years survival is about 98%. But like I said, it has not killed you. It is better dead than alive. That is when you present very early. At this early stage, you have this about 5 years. You can live if 5 people, let's say about 50 people will come and they are early stage. You can be sure 5 years time they will be alive. In respect with the prostate cancer. If African Electronics doesn't come in and compose something against the person, left with the prostate cancer alone, they can be alive. After 10 years, you can be sure that if they were 10, only 2 people probably would have. 98, 9, 10 is small. This one mathematics. If they were 100, about 2, only 2 people would have died with the prostate cancer at the early stage. But if you come at the late stage, survival is just about 32%. So if 100 people come, only about 32 people will be alive in 5 years. So to answer your question, this is how it can kill. Prostate cancer is really a killer. So I'll end my presentation here. So if you have any questions, you can ask. Thank you.
Thank you.
There's this interesting literature that says that if you're a man, the frequency of your firing, or the more you have sex, the less it is that you could develop prostate cancer. Going back to one of the slides that you showed, the first one, see that the thing was small down there. So does it mean if you kept firing, it will just diffuse and So I want to know the correlation between the frequency of a man's sexual activity and
prostate.
The research done that by some group of people that review that frequent sex like 5 times in a week. I don't know who has that energy. Reduces the risk, but a lot of other studies have actually counteract that finding, or they have been counter findings or researches that are reviewing something different. The first one was true, a research somebody found, but his population size, sample size was small. So it was not reflective enough. But with that small population he found that was the finding he had. The reason that they think that once you decompress the prostate, there is no congestion. You decompress it, there is no congestion. But it is not just the congestion. In fact, naturally, Naturally, the prostate clears itself. Naturally. You don't have to physically decongest before it decongests.
Your clearance rate is slow.
The natural
Naturally, so you see these holes here. That is where the prostatic secretions come in. So sometimes when there are a lot of the secretions, they come here and mix up with the digestive road. It's a very important question. So, as a matter of fact, I know recently all managers did the PSA. It's very good. So, if you can relax, in that case, you can do it every 2 years. Or somebody said some time ago that it's better to do your labs as your own birthday gift to yourself. You can decide to do it yearly or every 2 years. You are okay. Then we monitor. But if you did it and then the doctor said you have a prostate cancer and yours is a low risk, so we are putting you on active surveillance. Active surveillance, at least every 6 months you should do it. And the doctor should see you with assessment every 6 months. But if you did it and you saw a doctor and the doctor said you have a disease which is clinically significant, then by now you should be discussing treatment options based on the stage that you are.
Every unit has PC there. We have free Wi-Fi. Something will pass through our ears whilst we work, and I believe more people would have benefited from the presentation. Thank you.
Make announcement and publicity for many people to join. So, Doc, we thank you very much, for availing yourself and for letting us know this important information about prostate cancer. And then to the hospital staff, when we see you here, then we know we have medical cover. So thank you for also availing yourselves, and then managers to thank you, even though it was short notice. I think you've raised the occasion with your presence. So thank you very much, and thanks to everyone for coming. Thank you.